question. Uh-uh.
Thank you for the invitation to speak today on pain following adult spinal deformity and how I look at this, looking for a diagnosis rather than a syndrome. My name is Aaron Buckland. I'm an orthopedic spine surgeon at Melbourne Orthopedic Group. And here are my disclosures. None are relevant to the topic of this presentation. So the aims of adult spinal deformity correction really are quite simple. Number one, we want to correct the deformity, but the goal of correcting the deformity is to reduce pain, both by release of neurological compression, to obtain stability, and to restore alignment. We want to increase ambulatory distance, and we want to maintain safety above and all. So these goals are similar to adult spinal deformity, but the prevalence of complications are higher due to the higher invasiveness in adult spinal deformity when you compare them to other spinal pathologies. Now, obviously, patients think we can go in and use a laser and all sorts of minimally invasive techniques for surgery, but the realities of adult spinal deformity are somewhat different. They often require larger procedures, more bony work, and with higher invasiveness comes higher risk. So in understanding pain after adult spinal deformity correction, we also need to understand what that pain trajectory looks like post-operatively. So if we look at this, the timeline, you think about immediately post-operative, what your pain profile is, what's it like at 1 to 2 years during recovery, and what is it later down the track when other things may come up in terms of pain generators. I also want to know what the location of the pain is. Is it back pain? Is it the top, the bottom, or the middle of the construct? Or is it leg pain? If it's leg pain, is it radicular or is it non-radicular pattern? So this is an important study by Justin Shear and the ISSG some years ago, which showed that if you look at adult spinal deformity correction, you get pretty much all of your improvement in quality of life scores by 1 year, and then that's sustained until 2 years. And this was further replicated by Weber et al., who demonstrated, again, from about 6 months to 12 months onwards, that you've got that same improvement in pain up until 5 years post-operatively. So what we're looking for here is we know that patients will have an increased pain level immediately after the surgery, and it's going to take some time to note the improvement as their swelling occurs, as they start to get more stability and early evidence of fusion at those sites. And if I look at this, what I tell my patients is that in back pain, I expect that 30% of their improvement in the pain, and this doesn't mean 30% reduction in pain, but 30% of the benefit they're going to get is going to occur by 3 months. And 50 to 75% of the benefit they're going to get is going to occur by 6 months. But at 1 year, that's the final product. The other thing I tell them is that leg pain, given this is due to neurological compression, should be absent immediately post-operatively. And if it is present, that is abnormal. And if we look at what those pain scores look like, there are several studies which have demonstrated what the pain score reduction is. And most of them demonstrate that in terms of back pain, that you don't typically get an absence of pain. The mean preoperatively in most of these studies have shown a mean back score of 6 to 6.5 out of 10 and a post-operative score of 2.5. So I typically tell my patients, I'm not aiming for pain-free. I'm looking for a reduction from an 8 or a 9 out of 10 to a 2 to 3 out of 10 so that you are functional. If we then look at leg pain, again, adult spinal deformity, this is predominantly a back pain symptom, but there is a reduction in leg pain as well from an average of 3 to 4 down to 1 to 2. So this has been validated in several studies. So it is important in the outset to tell your patients there will be some pain still remaining post-operatively, but it should be pain that you can live with. So understand there's still going to be a small amount of pain and reasonable functional outcomes. It's important to know what is abnormal. And this is what's abnormal. When your patient's following a trajectory of improvement and then at some point starts to deflect off this recovery trajectory and starts to have increasing pain, be it back or leg. And that's something that raises alarm bells for me. So in terms of persistent back pain, you can look at surgery-related reasons. So post-operative wound pain should plateau or reduce by around 12 weeks, and by 12 months it should be comfortable. I always think about infection first and foremost, pseudoarthrosis, and this is something that I see missed all the time in my practice. Proximal junctional kyphosis or failure, equally so at the distal junction. This can occur if you haven't fused to the pelvis. And then instrumentation-related complications, being loosening, breakage, or prominence. Don't forget residual malalignment. Although it's not possible always to get perfect corrections, we need to be mindful that maybe we didn't hit our targets. And then there are other things above or below where you've done your fusions. Facet arthropathy, sacroiliac joint pathology, and don't forget the hips and knees for that matter. There are non-surgery related back pain that we need to think about. Particularly, you don't want to miss intra-abdominal pathology and you don't want to miss a AAA. So always in the back of my mind, I'm thinking these things where I can't find an obvious source from the surgery site. In terms of leg pain, well, always be critical of yourself. You want to make sure that you have actually adequately decompressed. So I've got a low threshold to scan these patients with leg pain postoperatively. You want to know that you haven't put the instrumentation in the wrong position. And thankfully, this is less and less common with modern technology such as navigation and intraoperative 3D imaging, but it does still occur. There are still some patients that have chronic nerve damage, but to me, this is the diagnosis of exclusion. This is not the first thing I think of. And don't forget non-spinal causes for pain. Do they have peripheral neuropathy? Do they have vascular claudication, hip or knee osteoarthritis, or are there other musculoskeletal pathologies that may be mimicking this? So if we start with alignment here, this was pretty well defined by Frank Schwab, Jean-Pierre Farcy, and Virginie Lafarge. I had the pleasure of working with them when I was in New York. And they defined this with the International Spine Study Group and developed these thresholds of where you want to aim for your pelvic incidence lumbar lordosis mismatch, your global alignment, and your pelvic tilt. It is important to understand that this is not the be-all and end-all of obtaining good results. It only accounts for about 16% of what we're looking for. So there's other 84% that is not explained by alignment. And the reason I use that number is if you look at the correlation coefficients, the best they had was 0.4. So the R squared is actually 0.16. Age-adjusted alignment is becoming more important. As we know, patients age, they become more kyphotic, and they also get weaker bones. So if you go for alignment targets of someone who is much younger than them, you're more likely to produce a complication and end up with a worse outcome. So we've changed the way we've thought about this and looked at age defining and now even pelvic incidence defined as well as age defined thresholds that Dr. Prodopsoulos in New York City has also uncovered in recent years. So rod breakage and pseudoarthrosis, typically these patients tend to get better for about 6 to 12 months and then they have a recurrence of pain. They may even feel a crack or notice a loss of correction at the time. So it's important to ask the patient about those things. On CT, some of the things you may see are screw loosening. You may have incomplete bony integration across the disc, or a vacuum disc is often seen. Sometimes I will use CT or even SPECT CT to look for persistent tracer uptake at the level of the pseudoarthrosis or at the start of the loose instrumentation. You've always got to be careful when using SPECT, however. In the first 12 months, this will light up bright, even if there's an absence of pseudoarthrosis. So this can be a false positive. So in diagnosing pseudoarthrosis, sometimes it's very obvious. You have a rod breakage or obvious instrumentation loosening, but sometimes it's not that obvious. You might have partial integration. You may not be able to see a rod breakage because it's under a screw cap, for instance. So history is absolutely paramount. It is actually quite common, occurs in 5 to 10% of multi-level fusions, and even 15 to 25% of deformity surgeries of more than 5 levels. So be aware of it. And if you hear that history of the back pain getting better and then getting worse at that 9 to 12 month mark, that should be one of the first things you think about. Unilateral rod breakages, even though the pseudoarthrosis may settle in terms of their pain and not need treatment, once you've got bilateral or you've lost correction, these certainly need treatment. And this is an example of screw loosening that you may see. You can see haloing around the screws there at that L3 level, incomplete bony fusion across the facet joints there, but you see complete fusion at the level below. Rod fractures certainly occur with osteotomies. If you do either posterior column osteotomies or pedicle subtraction osteotomies, you can actually increase your risk of rod fractures and pseudoarthrosis. So I always tend to think of rod fracture and pseudoarthrosis as the one entity, and increasing a number of rods probably delays rod breakage, but if it doesn't heal, it doesn't heal. Your rods will fail eventually. And the reason that you see high rod fractures here with bigger releases is that you're actually destabilizing the spine more. If you do a pedicle subtraction osteotomy, you put more stress on the instrumentation, it's more likely to loosen before fusion is obtained. The other important thing with a pedicle subtraction osteotomy is that bone apposition and technique are very important, and sometimes you have incomplete apposition of the osteotomy to obtain fusion. There are independent risk factors for rod fracture, pseudoarthrosis obviously being an obvious one, rod contours or over-contouring rods of greater than 60 degrees, crossing the thoracolumbar or the lumbosacral junction, and parallel connectors. Now, whether parallel connectors is due to it taking up space for bone graft or there's just regional excessive stiffness, it's still unclear. I would argue that potentially people are trying to use parallel connectors to add instrumentation rather than looking at the biologics of fusion, and that could be a confounder. So after PSO, you can see it's very, very common. It's an independent risk factor after pedicle subtraction osteotomy for rod breakages, and this has been demonstrated in several large studies. So in terms of preventing rod breakage, I don't think it really matters whether you use 2 versus 3 versus 4 rods. It may just delay rod breakage. Rod materials doesn't seem to matter. Cobalt, chrome, and titanium seem to be better than stainless steel. The titanium is more notch sensitive. There's no evidence really to support one over the other. I try and reduce my rod notching as best as possible, have a smooth curvature to my rod. So if you can use Bandini, for instance, make sure it's on the smooth contour, not the more acute contour. I use interbodies more and more, and I'm using less and less rods. So I'm usually typically using 2 rods now, but putting interbodies in all of the discs in the lumbar spine that I can get access to via minimally invasive techniques. Because what you're looking at doing here is sharing the load between the front and the back of the spine, but also you get a better fusion through the disc space at those levels. And lastly, and probably most importantly, you want to find strategies to avoid a 3-column osteotomy or pedicle subtraction osteotomy. And the reason for that is you're taking bone away and producing a gap of which you've got to fuse across. Not only that, but there's higher rates of bleeding, higher complications. So if you can find an open disc space, you can use hypoaldotic implants. You can maybe do multiple smaller osteotomies across a region to get correction. These tend to be better options than doing a 3-column osteotomy, as we're finding out. Don't forget about adjacent segment degeneration. Again, this is another issue that you can have not in the immediate postoperative period, but many months or several years down the track. This would be an onset of new back pain or neurological symptoms. The distribution of leg pain, for instance, may be radicular or claudicant. The low back characteristics might be mechanical or again, claudicant back pain. So don't ignore these. Some of the more challenging complications to deal with in adult deformity, however, are your proximal or distal junctional problems. Proximal junctional kyphosis is very common, occurs in about 1/5 to 1/4 of patients in adult spinal deformity correction. And most of these will happen in the first 8 weeks or so, but 3/4 of them will happen by 3 months. So this is usually something that happens earlier in the piece. Proximal junctional kyphosis doesn't necessarily need to require further surgery. The times that you would need to do further surgery for this are if the loss of correction provides unacceptable sagittal alignment, or if you have persistent pain at the area of the kyphosis. This is a different beast, however, proximal junctional failure. So failure is more of a problem than kyphosis because you've either got fracture or subluxation and you've actually lost that bone implant interface. There's more potential for neurological injury because there's instability and deformity around the cord. And typically you'll address this by extending proximally in the setting of proximal junctional failure. Now, the same goes for distal junctional failure. For the most part in adult deformity, however, we're talking about fusion to the pelvis. SI joint dysfunction and degeneration is a newer topic that I've come across only in the last few years. And certainly when I inherited a deformity practice in New York, I started to notice a lot of buttock pain. It wasn't even being solved by S2AI screws, which is what I was led to believe was the new panacea in pelvic instrumentation. We're becoming better and better equipped to deal with it. Certainly, I've seen loosening of S2AI screws despite solid lumbosacral fusion. If that happens, you must be moving across your SI joint. And with those patients, when I've gone back and fused the SI joint, their pain's gone away. So this is something that I primarily fuse SI joints at the start when I do their fusion to the pelvis to try and avoid distal junctional problems. We actually think that fusing the SI joint may actually protect your iliosacral screws or S2AI screws to stop them from loosening, because when you lose them also it's difficult to revise these when you start losing large amounts of bone. There's only so big you can go in terms of screw diameter. I always carefully examine the hip to look for osteoarthritis and femoroacetabular impingement as well, and piriformis syndrome when I'm considering SI dysfunction. I can't say I've ever actually seen piriformis syndrome. It's often quoted but rarely diagnosed. But don't forget about these other pathologies that may cause buttock pain, which we've so often just attributed to our pelvic instrumentation. There is some evidence, if you look at finite element analysis here, which demonstrates that longer fusions to the sacrum put increased stress on the SI joint. So with long fusions such as spinal deformity to the pelvis, it's little wonder that we're putting more stress on the sacroiliac joint. Here you can see this is evidence that the incidence rate increases significantly if you've got at least 4 segments fused by the SI joint. Almost a quarter of patients can develop SI joint pain. So it's worth looking for, it's worth trying to understand this, and I would argue even worth fusing the SI joint with your primary fusion to the pelvis. Now, in terms of persistent leg pain, timeline is important here. If this is present immediately post-operatively, this is abnormal. You need to investigate it. It's often instrumentation related, or you just haven't done enough in your neurological decompression. If it's in the early post-operative period, what can often happen is that if you get some toggle around instrumentation that was adjacent to the nerve, it can become symptomatic after the first few days or first weeks. Or radiculitis, as the nerve swells and you start to get nerve root recovery, that can occur, but that's usually self-limiting. And the late problems here, adjacent segment disease, pseudarthrosis can certainly present with leg pain. Don't forget SI joint dysfunction, that can also present with leg pain because the lumbosacral plexus runs over the anterior aspect of your SI joint. And then again, non-spinal pathologies. I tend to investigate these whenever I have leg pain in the early post-operative period. This is an example of one time I was burnt 2 years ago, where you can see a persistent, long, superior articulating process skewering the L5 nerve root, where I thought I could get indirect decompression from my ALIF. I didn't appreciate that. So we did a foraminotomy and the pain went away here. Make sure you do a careful history and physical examination, do your imaging, and if you're still not sure, do an EMG or nerve conduction test. Treating the pain, well, early, you can use corticosteroids or GABAergics if you think it's something self-limiting, such as a radiculitis. You might also consider an epidural steroid injection, and I perform these under CT guidance in radiology. If it's not getting better, then surgical decompression or implant repositioning, if you find there is a technical error, is important to do in the early phase. The later leg pains, you want to confirm the solid fusion and no adjacent segment disease. You want to address what other potential causes there could be, such as peripheral vascular disease or other musculoskeletal pathology. And if I still can't find anything there, then I'm referring to pain management. And then I'm thinking about injections, neuroleptic medications, and in the odd occasion, spinal cord stimulator. I'd say this is probably something I've seen too much of from pain management specialists, but they actually do work well for patients who have persistent neurological pain in their lower extremities with no evidence of persistent neurological compression. It doesn't work for back pain. I think that's the important thing to mention there. So how do I work them up? Understand recovery kinetics. When is the pain abnormal? So early post-op period may not be. Late post-operative period is much more common to be abnormal. If they never got better, consider that it's a treatment of your failure of your treatment, or it's even a failure in diagnosis, and maybe you didn't have the diagnosis to start with. So you need to investigate further and be critical of yourself to look for these errors. If it was better initially and then recurred, it's not a chronic pain syndrome. It's a pseudarthrosis. You've got an adjacent or segment problem, proximal distal junctional problem, or progressive degeneration in a level that wasn't fused. So don't just put them in the chronic pain basket, as many pain specialists do. Examine them, examine them, examine them. Be critical of your surgical site. Check their alignment. Make sure you met the goals that you set yourself. Check neurologically that you haven't got new weakness or new numbness. And examine the joint above and below. Don't forget the hip. Don't forget the SI joint. Don't forget the shoulder in the case of upper thoracic or cervical spinal procedures. And once again, don't forget your vascular examination. You need to exclude ischemia or AAAs in these situations. I'll always re-image a surgical site, first with radiographs. If that's not obvious, I'll get a CT. SPECT scan if it's greater than 12 months and the CT's unequivocal. And an MRI if I think there's persistent neurological symptoms, although this can be very difficult to interpret in the setting of a lot of instrumentation. Image the other joints that you think may be causing symptoms. If you're still unsure, think about an EMG or nerve conduction test. And if you're still not sure, then diagnostic injections of the painful joint, not with an epidural, can be helpful. And how do you treat this? Well, you got to treat the primary cause. If it's a technical error, you need to correct it. If it's a new pathology, you need to treat that pathology. If it's a diagnostic error, you need to be able to treat that pathology. And if it's not something you treat, pass it on to one of your colleagues to do so. If it's a self-limiting pain generator, then supportive measures until resolution are important. That may include medications or injections. So in the setting where there isn't a technical error, where there isn't persistent deformity, and there's no other clinical diagnosis that can be obtained, this is when I consider it to be a chronic pain syndrome. And always consider and treat concomitant psychosocial illnesses. Sometimes back pain can be the outlet that people find acceptable, but really it's a psychological illness that's driving it. So I've looked back over the last 5 years at what I've changed, and after seeing complications associated with spinal deformity correction, more and more I'm applying minimally invasive anterior column fusion in addition to my posterior open fusion in order to get better correction, share the load, but also reduce rod breakage or pseudoarthrosis. I'm often staging the correction now instead of trying to do a lot of interbodies from posteriorly, increasing bleeding and doing a lot of bony work. I'll do my anterior column on a Friday and then come back on the Monday to do the posterior aspect. I'm reducing how many osteotomies I do. I look for open disc spaces to do larger corrections, and I try and do this via hyperlordotic A-lifts, via X-lift or anterior column release. And this is something that certainly 5 years ago in my practice, I was trying to use T-lifts and osteotomies for everything. I found this to be less invasive and have less complications. And I'm now fusing the SI joint wherever able. And here's a couple of examples. This is a lady that has severe sagittal plane deformity that we need to do a T4 to pelvis fusion. You can see I've used a combination of A-lifts and X-lift in addition to a T4 to pelvis fusion, so we could get better interbody support and fuse both SI joints. Another example here of using anterior column support, both A-lift and X-lift. We're actually able to shorten her fusion levels. I would typically have gone T4 to pelvis here, but by giving better anterior column support in the upper lumbar spine at the apex of the deformity, I was able to shorten my construct. So conclusions here, back pain and leg pain are common, although they're typically not severe and they usually shouldn't be functionally limiting. Careful history, physical examination can usually elicit the cause, and you need to be critical that maybe you didn't achieve the goals that you set out to achieve. Consider non-spinal pathologies, don't miss them, and avoid the use of blanket diagnoses such as a chronic pain syndrome or failed back surgery syndrome or post-spinal surgery syndrome. They're not diagnoses. They often neglect the underlying cause. If you wish to look at this further, we can suggest this is a paper by Dylan Proctor and myself in Spine Seminars. Feel free to have a read of that further. Thanks very much.